Live from the Washington, D.C. area, it's the Inside Scoop. All the news that our viewers want to know. Now, here's the host.
Good evening, and welcome to the Inside Scoop. I am your host, Melissa Batchelor-Murphy, and tonight we will continue our series on healthcare and health-related issues. My background is in geriatrics and long-term care, and one of the things that I have seen with older adults and their family members is knowing what services are out there to help take care of their older aging parent. Our focus tonight is on geriatrics, the super specialist. The National Academies of Science, Engineering, and Medicine, which used to be called the Institute of Medicine, released a report last year called Families, Caring for an Aging America. At least 17.7 million Americans are providing care for someone over the age of 65 because of a limitation in their physical or mental functioning. On March 10, 2017, the Washington Post ran an article asking if it was worth it to start using a geriatrician. The article and I agree that it is a good idea, just like taking your child to the pediatrician is a good idea. When you have a lot of medications and health problems that you and your family are trying to manage, geriatricians are experts in complexity. My first guest tonight is Dr. Denise Mohess, who is the Section Chief of Geriatrics and the Medical Director of the Advanced Illness Clinic at Inova Health. She is trained in internal medicine, geriatric medicine, and hospice and palliative care. Welcome to the show tonight, Dr. Mohess.
Thank you.
And I know I just messed up your title, so why don't you just clarify that?
I'm the Medical Director for Advanced Illness and Geriatric Programs at Inova.
Okay.
Close enough.
All righty. So tell me how you kind of got interested in geriatrics, because it's not a common career choice for a lot of people.
So I remember as a second-year internal medicine resident, everybody else was fighting to get into the other subspecialties, cardiology, endocrinology, and the fancy things. And I was really interested in learning how do I really care for older adults. So initially I looked at other disciplines like rheumatology and other things, but I really was seeking more personalized care for older adults rather than just focusing on one organ system or one disease process. I kind of stumbled upon a quality improvement rotation, and during that time we were focusing on developing a geriatric service line, looking at falls and delirium. So I was given the opportunity to work with the geriatrician and the nurse practitioners and other team members who were trying to develop this service line, and then I got hooked. I knew that that's what I was searching for. With palliative medicine, I had to take care of a dying patient one night, and this patient and family were in a lot of distress, and I saw the palliative care nurse practitioner was able to come in and really turn what was a crisis into a peaceful, sacred moment for the family. And I recognized as a resident, even though I was not able to help cure this patient's cancer, we were able to help the family at a most sacred time. And I thought that's something I wanted to do too. So then I did my geriatric fellowship after my residency, and then followed that with a palliative care fellowship.
Okay.
And here I am.
And so you're the division chief of geriatrics,
correct,
or section chief of geriatrics. So tell me, what do you do in that role?
So I am honored to be able to be overseeing inpatient geriatric consult service at Inova Fairfax, as well as the outpatient geriatric services. So we'll talk later today about some of the other services. So we have a geriatric advanced illness clinic, a geriatric comprehensive assessment clinic, and a medical house calls program. And then we partner with other community programs like ElderLink to be able to provide resources in the community for patients and families caring for older family members.
Okay. Yeah, so I think I was recently part of a community health needs assessment that Inova had done, and I think it's great that of your top 3 priorities, elder care is your number 1.
Right.
So I think I was reading an article recently in the American Journal of Gerontological Society, and Dr. Morley had published an article that talked about geriatrics as kind of the super specialist. And we have a slide that kind of talks about some of the different things that you can do in geriatrics related to educating. So I kind of think that this healthcare series is helping to educate the public. You know, the inpatient hospital consult services, and we've got you and I have scheduled a couple of shows in the next couple of months to highlight those features.
Right.
And also long-term care. You touched a little bit on end-of-life care, and then geropsych. So tonight we're going to kind of talk about this model that was in this publication, and how geriatricians work with nurse practitioners and the interdisciplinary team to provide care from an outpatient service perspective. So maybe you can tell me a little bit about the advanced illness clinic.
Yeah, so I think what's really key about geriatric care is that it has to be interdisciplinary. It's more than just the physician or the nurse practitioner providing the medical care. We have to approach patients in a comprehensive manner, addressing the psychosocial needs, the spiritual needs, the emotional needs that come with becoming older. Sometimes there's cognitive impairment, sometimes there's functional impairment. So I think taking an interdisciplinary approach is key, and that's what we're doing here at Inova. With the Advanced Illness Clinic, we would be focusing on patients who have a life expectancy of probably 2 years or less, multiple comorbidities, maybe too complex now for their regular primary care physician to be able to manage. Maybe it came with multiple hospitalizations and now they're leaving with multiple medications. So we at the Advanced Illness Clinic would be happy to have those patients come to us, and either we become their primary care providers to be able to help stabilize them, and also to help deal with the polypharmacy, which is multiple medications, clean up the medication list, simplify it, make sure that they're taking the right medication at the right time, and being able to support them in that. In addition, we would be able to focus on goals of care discussions around where do we go next, how much do we do, how many times do we go back and forth to the hospital, and how can we help these patients stay at home and remain functional in their own home. Some patients may have had their primary care physicians for 20 years, and then that's fine. We may be able to help stabilize them, and then they can go back to their primary care physicians. We recognize that the primary care physicians now, they're very time limited. When they have to see patients, everything is very much of a crunch. So these patients with medical complex illnesses they need more time. At the Advanced Illness Clinic, we would have the luxury of having more time to be able to delve into the complex needs of the patient.
So if one of our viewers isn't familiar with all of our lingo, because we love to use those big words as in geriatrics, tell me, how would a person in the community without a lot of healthcare experience recognize what multiple comorbidities and complex, what would that look like in a family member?
So it may be that it's more than 2 chronic illnesses. For example, things like diabetes, hypertension, high cholesterol, maybe heart failure, lung failure, multiple hospitalizations. So you're going to the hospital many times. For example, in 3 months, you've been admitted to the hospital more than 2 or 3 times. There's functional decline, there's memory impairment. Things aren't just what they used to be. And it's becoming more complicated because the medication list is probably growing as well. And now the needs are more than they used to be from a functional perspective as well.
Yeah, I mean, that's actually one of the reasons why I got into geriatrics, because, it was always complex. You would have 10 different diagnoses from heart failure, all the way down. And then, I think most older adults take at least 5.
Right.
Medications or more. So I think those are 2 things that people can think about. If you're taking 5 or more medications, that's a complex situation, because I know that at my age, I'm not taking 5, I'm not taking any other than my vitamins. So so in addition to kind of your general training as an internal medicine provider, kind of what makes geriatrics different? Like, what do you guys bring to the table that's different than family medicine or primary care?
So after your family medicine training or your internal medicine training for geriatrics, you would do additional training for 1 to 2 years, And during those years, you focus on the geriatric syndromes. So really what makes a geriatric patient different from a regular patient or when you were younger. So the things we specialize in would be what we call geriatric syndromes. So cognitive impairment, so memory loss, or the forgetfulness that we sometimes think it's normal.
Yeah. Or trying to figure out if it's normal or not.
Exactly. Then there's a functional impairment. So maybe the gait or the walking or the balance is off. Maybe there were recurrent falls. Urinary incontinence, constipation, frailty, weight loss, loss of appetite. Sometimes they're easily reversible causes for loss of appetite in an older patient, more than just, well, you're getting old, and we can help look into those syndromes. I think one of the other things that is focused a lot in your additional training with either geriatrics or palliative care is communication. Learning to communicate with older adults and their family members, whether there's sensory impairment from hearing loss or vision loss, but there's also that you're going to take your time and speak and really evaluate from patients what are their goals, how do they define quality of life. And I think those would be the things that we would also look at in the advanced illness clinic, because we would also be doing palliative care consults for patients who had symptoms. For example, older patients with pain, shortness of breath, anxiety, fatigue. We can help manage those symptoms, but also having lots of conversations and discussions about what is the overall goal. How do we help you develop a plan that is consistent with how you define quality of life?
And so one of your in palliative care, and kind of how's palliative care different than hospice? Because I think a lot of people are very familiar with the term hospice, but maybe not so much with palliative care. So
I tend to say palliative care, any age, any stage. So I'm a geriatrician, but I also see babies. And so palliative care can happen concomitantly or concurrently with curative medications or curative treatments, whether it's surgery, radiation, chemotherapy, whatever the illness is, you can have both, where palliative care is focusing on the physical, psychosocial, spiritual, emotional distress, managing those symptoms for you so you can continue to get your treatments and tolerate your treatments. Hospice comes into play when there's probably a prognosis of about 6 months or less, or there's no longer curative treatment. So hospice would be palliative care closer to the end of life. It's not imminently dying. You can have a prognosis of 6 months. Even we've had patients on hospice for a year, as long as you have that diagnosis and curative measures are no longer available or no longer being pursued.
So if we wanted to get in touch with you about this advanced illness clinic, what would be some ways that we could get in touch with you?
So on the Inova website, and I think we were going to share that, the advanced illness clinic, like some of the other clinics that we would talk about later this evening, are based at the IMG Oakton office, and we'll share the phone number.
Yes.
Okay.
The phone number will come up repeatedly throughout the afternoon or this evening session. So thank you very much for that, and we will be right back to talk about the House Calls program within Inova Fairfax. Thank you very much.
Patriotism. It inspires passionate debate, and it's worn like a badge of honor with good reason, because it means love and devotion for one's country. Love. But what really makes up this country of ours? What is it we love? It's the people. Almost half the country belongs to minority groups. People who are lesbian, African American, and bi, and transgender, and Native American, and proud of it. After all, what's more American than freedom to celebrate the things that make us, us? This year, patriotism shouldn't just be about pride of country. It should be about love. Love beyond age, disability, sexuality, race, religion, and any other labels. Because the second any of us judge people based on those labels, we're not really being patriotic, are we? Because love has no labels. Thank you. You got a king?
Good.
Fish. In your face, in your face.
It only takes a moment to make a moment. Take time to be a dad today.
Are your children in the right car seat for their age and size? It may be too late to check when you're on the road. Fortunately, you're on the couch. Don't think you know. Know you know.
We're back to the Inside Scoop. Here again, your host.
Welcome back to the Inside Scoop, the healthcare series. I'm your host, Melissa Batchelor-Murphy, and tonight we are talking about geriatrics, the super specialist, and about the new services that Inova is offering to older adults and our families in the community. Dr. Denise Mohess just provided an overview of what geriatricians do and how they are different than family or internal medicine physicians, and gave us some information about the Advanced Illness Clinic. I'm now joined by Marlow Phillips, who's an adult gerontological nurse practitioner for primary care, and Nancy Toward, who is a social worker, both within the Inova House Calls program. And this is a program that provides services, just like the name says, at home. So I'll start with you, Marlow. I'm also very proud tonight to let everyone know that Marlow is an alumni of Duke University School of Nursing, where I am faculty. Yes. So she graduated in December 2015, and 2 weeks ago we were announced as the U.S. News and World Report #1 School of Nursing. Yeah. It's the first time in our history, so we just had to take a moment during ACC season to talk about that. So tell me how you got interested in geriatrics.
So I worked for quite some time in the hospital and on different surgical floors, and I found that the geriatric population was just treated like your normal 40, 50-year-old person with, medical conditions. And they're really a unique population, similar to, you would think of like a pediatrics, like they're a very unique subset of the population. So I noticed that they had some unmet needs throughout my time in the hospital, and I really ended up falling into primary care because I wanted to be more proactive about that population. I really wanted to build rapport with patients, teach them about their illnesses, and try to prevent hospitalizations from occurring before they ended up in the hospital. I saw too many sad cases before it was too late to help.
Okay. And so as an adult gerontological nurse practitioner, tell me a little bit about how your training prepared you for that role.
Yeah, so as a nurse practitioner, I've completed, a bachelor's degree in nursing, and then I have about 8 years of nursing experience. So, and then I obviously completed my degree at Duke, which was such a wonderful experience.
For your master's?
For my master's, yes. And so really it was a culmination of all of that time that really led to my nurse practitioner experience, because you pick up bits and pieces in the hospital, you pick bits and pieces through clinical rotations, and that really prepared me to join as a nurse practitioner at Inova.
Okay. And we met in orientation, so that was a fun place to meet as well. And so, Nancy, tell me a little bit about how you, as a social worker, decided that you wanted to work with geriatrics.
Sure. So for many years I had worked with adolescents and with children, and I'd never had the experience to work with the older adult population. And I really wanted to be able to say that I've worked across the lifespan. So when the opportunity presented itself, I took that opportunity, and it's been a wonderful experience to work with the older adults and really help them face those challenges that they do experience, and they're very unique. And I've really enjoyed it.
Okay, and you're also what's a certified senior advisor.
That's correct.
So a CSA. So that was a new term for me. So tell me kind of what that adds to your work as a social worker.
Sure. So coming from the world of children and adolescents, I had heard about this CSA course, the Certified Senior Advisor, and what it is essentially, it's a training program, and it teaches you about health concerns facing older adults, financial, legal. It's essentially a crash course in the world of older adults. It also teaches you how to communicate effectively with them. So at the end of that study and that training program, I took an exam and became certified as a CSA.
Okay. That's great to know, because there are a lot of different disciplines within geriatrics, but good that you kind of went the extra step to gain that experience. So there's another member of your team, and I think he provided a video so that we could meet the geriatrician with our house calls program. So Dr. Hilburn, we could just go to his video and let him introduce himself and kind of what his role is within the house calls program. So maybe we can just talk about Dr. Hilburn while we're trying to find the video.
Our team is comprised of Dr. Hilburn and then 5 nurse practitioners, 2 social workers, and then office staff. Everybody is a really close-knit team. Dr. Hilburn comes with quite some experience in a house calls program. He has worked at the VA for some time and actually started his own house calls program, and so joins us with really a lot of experience with the house calls program as well as geriatrics experience.
Yes, so about 30 years is what his bio said.
Yeah. So we are very honored to have him as a member of our team. So he will, the process, the way it works is that he will do that initial admission on the patient, and then the nurse practitioners will come out and we will be assigned those patients. So he does that initial intake and then is a liaison on really all of the cases of our patients.
Okay. So who's eligible to be in the house calls program?
So eligibility, it has to be 60. We're geared towards the geriatric population. However, we do have some patients that are younger than 65. They have to be homebound, whether it be blindness or a stroke or some type of physical ailment that the one hard stop is they can't be driving. But that doesn't mean that they can't leave the house, on an intermittent basis. It just needs to be physically taxing for them to do so.
So I think we have the video, so let's go ahead and slide Dr. Hilburn in here.
Hi, I'm Rick Hilburn. I'm a physician with the Inova Medical Group in the Department of Geriatrics. I work with a specialized house calls team. We're comprised of myself, 5 nurse practitioners, 2 social workers, and an administrative assistant. Our purpose is to bring to the patient's home primary care, same as they would access in a clinic, except we bring the clinic to them. Our patients are typically disabled by such things as strokes, dementia, heart attack, or a host of chronic diseases that render it very difficult, if not impossible, for them to access routine primary care appointments in a clinic. If we succeed in our mission, we'll reduce the patient's need to go to the emergency room, help them avoid hospital admissions, and so forth. Our team is able to coordinate appointments with specialists and with community resources, and essentially we operate as a center point in the patient medical home. You can reach us at 571-328-7775. Thanks for listening.
So that was great. And he gave the phone number, which we will continue to show throughout the segment so that people know how to get in touch with you. So you kind of did we get to everything with that initial overview?
I think so.
Okay. So you're a social worker.
I am,
so maybe you can kind of talk to us about what a social worker does and kind of what your role is within the house calls program.
Sure. So typically the nurse practitioner or the primary care physician will refer cases to us. And that will be because they have some needs that are outside or beyond the scope of medical needs or what the nurse practitioner or primary care physician can do. So we will receive that case, and what we do, the first step is to schedule the initial home visit. So we'll go out and complete a comprehensive psychosocial assessment that will look at different areas. It'll look at cognitive functioning, family history, financials. It will look at the home environment, safety, and supports in the home. And the reason for that is to get a fairly good picture of that patient and that family. From that point, we can complete a care plan with mutually agreed upon goals with that patient and their family and start working towards that goals. But we really respect where the patient is and where they want to go. So we keep in mind, the patient's independence and their autonomy along the way.
So do people have to live by themselves, or can they live with family members?
They can most definitely live with family members. To be honest, a lot of patients living with family members are experiencing their own set of difficulties. We have family members who are serving as caregivers, and at some point they're giving so much of themselves that they really have nothing left. And they need support with dealing with patient care, and also support because it just becomes very burdensome and exhausting. So at times we're looking at referrals to respite care. So that respite care can be in the home, it can be respite care in a facility, or even support groups. And more support groups are popping up all over the county, and these are wonderful.
Yeah, so the word respite just means a break.
Exactly, a much deserved break.
Yes, because I think there's, when you're trying to navigate the system and care of older adults, there's so many words you have to learn, like an entire new vocabulary. So the word respite means break, and your job is to help connect those family caregivers to the services in the community that we may have talked about some of them, but there may be some that we still have left to talk about. So what would a typical visit look like for you, Marlow?
So I kind of wear all hats, or the provider that comes out wears all hats. I'm the scheduler, I'm the phlebotomist, I'm the nurse, I'm the medical provider. So in one visit, it typically lasts 25 minutes to an hour. I drive up, give them an hour window, or a few hour window of time, kind of like the cable guy, unfortunately. So I'll arrive, if there's family members present or caregiver present, I'll try to get, if the patient's not able to give history, I'll get history from the caregiver or the family, assess the patient, do the vital signs. If they need extra tests like x-rays or lab draws, we're able to do that. We've partnered with a couple suppliers in the community that are able to do x-rays, EKGs, echocardiograms. So those just help to limit the need for the patient to leave the home. And then we see the patients, we try to see every patient at least monthly. I'm able to see patients same day if they call and say, hey, I'm feeling short of breath today. I'm able to swing by and squeeze them into my schedule. So our goal is really to prevent the patients from using, the emergency room and using the hospital as their first line of defense. We really want to be their primary point of contact with their health care.
And decreasing those transitions is always helpful for patients and families, because the less you have to go to the emergency room or in the hospital, the better off you're going to be. So when we come back, we will continue our discussion talking about the House Calls program and kind of what other services are offered through this particular program.
Strawberries? Okay.
Okay, so what would you bring to my company?
What do you need?
I need problem-solving skills.
I got through high school without a car, a phone, or a computer.
No college degree, though.
Not yet, but life's taught me a lot, and I'm ready for more.
Well, you're not the typical kind of candidate that I hire. But you are exactly what I'm looking for.
your company could be missing out on the candidates it needs most. Learn how to find a great pool of untapped talent at gradsoflife.org.
They'll test you. Try to break your will. But however loud the loudness gets, however many cheese puffs may fly, you're the driver, the one in control. Stand firm. Just wait. And move only when you hear the click that says they're buckled in for the drive. Never give up till they buckle up.
We're back to the Inside Scoop. Here again, your host.
Welcome back to the Inside Scoop, the healthcare series. My name is Melissa Batchelor-Murphy, and I'm your host this evening. And we are talking about the new House Calls program, which is a really innovative model of caring for older adults in our community that Inova Health System and Inova Fairfax has undertaken. So I'm joined in the studio tonight by Marlow Phillips and Nancy Toward. So Marlow is our nurse practitioner, Nancy is our social worker on our team, and we just had the opportunity to meet Dr. Hilburn, who's the geriatrician that works with you guys. So we've talked about what a typical visit looks like and who's kind of eligible for this program. So let's talk a little bit now about the benefits of being in the program and how you kind of get connected.
So the benefits of being in the program is that, really it takes some of the burden off the caregivers to having to take the patient to a doctor's visit that oftentimes they'll have to wait for, a lengthy period of time. And if there's any physical ailments, it's hard to transfer in and out of a car. Weather can play a important factor in getting somebody to the doctor's office. So, we kind of take that question mark out of it and hopefully make it more accessible for the geriatric population. As far as how people get connected with the program, the phone number we've mentioned multiple times. There are a couple more kind of constraints, I guess, that maybe Nancy wants to mention.
Sure. So besides the 65 or older and being homebound, that homebound criteria, the patient also has to have, typically the patient has Medicare and then another insurance which can cover that additional 20%. So Medicare covers in doctor's office visits an 80% charge, and then the supplemental will pick up 20%. If a person does not have supplemental insurance, that would be an out-of-pocket cost. Additionally, patients have to agree to transfer their care to our primary care provider. So that can be difficult for some patients who have been seeing the same primary provider for many, many years. But thankfully, a lot of patients have chosen to transfer over because it is so much more convenient.
And even that out-of-pocket copay would be the same whether they went to the doctor or not. I mean, if you don't have, so it's not like it's a detriment to your program. It's kind of the same payment.
Exactly. There's no additional cost for transportation. And in regards to social work, it is difficult to get a social worker in the county or a case manager, especially a geriatric case manager. It's fairly expensive in the community to hire somebody. That price can range between $120 and maybe $200 an hour for a good geriatric case manager. So they're receiving those services and really getting their needs met, learning about resources they may not have known about. So there are a lot of benefits when they join us, and having the resources of the nurse practitioner, the primary care physician, and the social work.
Yeah, it goes back to that complex needs and kind of how to help reduce the stress on family caregivers and the older adults. So Marlow, you were nice enough to talk to some family caregivers and one of your patients. So I think this family caregiver does a really good job of explaining kind of how he sees this program benefiting. So is there anything you want to say before we watch the video?
So Joe is the son of you'll see the patient actually later in the clip, but so Joe does an excellent job of caring for his two elderly parents. And so he just talks a little bit about how the program has benefited him, because I think sometimes we don't think about how we're always patient-centered as the medical provider, but it really helps the whole family. So it's interesting to hear his story.
So let's look at the video now of this son who's a family caregiver.
Hi, my mom came home from a rehab center, Fairfax Nursing and Rehab, and she needed a live-in caregiver while she was here, and immediately we had to start following up with her own doctors. That was a problem. Luckily, they told us about the Inova Geriatrics that would send doctors and nurses to make house calls, and that's been a real lifesaver for us because getting in and out of our house with a number of stairs was possible, but generally very difficult for my mom to do, particularly if she had to go for frequent follow-ups. So the Inova Geriatrics has really helped her out. The people have been great. They've not only have they come for routine scheduled appointments, but when we've been able to call them for, if anything goes wrong or if we have any questions, they can make extra visits to see what's going on. It's just been a real godsend for us. And not just for her, but I hate to be selfish, but for me as well. Because if she did need to get to a doctor, I might have to come home and be helping her out, helping to get there. So I don't have to take time off of work to see that she's getting the care she needs.
Yeah, so he brings up another good point about family caregivers having to miss work, to help get people around to these doctors' offices. So I really think the house calls program is great at kind of bridging that gap. And so the second video is of one of your patients, Miss Jean. So maybe you can tell us, I think the biggest thing after I watched this video was that I think that the sense of comfort and security that you bring, that's really kind of what I heard from her. So I'll let you
That's sweet of you to say. Unfortunately, Jean's husband passed away this past week. So I spent the majority of my day figuring out how we were going to transport her to his funeral. So, I think that kind of goes, we see a lot more than you would see in the office. And so, we're looking at the patient really holistically, like coupled with the social worker. Nancy gave me the resource. I was able to give the phone call. It's just really this comprehensive care that we're providing for the patient and really looking at not just the medical needs, but, spiritual, emotional needs that they see as well.
Okay. Well, let's take a look at Miss Jean.
Right. Why don't you tell us your name?
Jean Landrum.
Yeah, and how old are you, Jean?
92.
And tell us what, how the medical house calls program has helped you.
Oh, I can't say enough. I am so pleased with all of them. In the beginning, it was 2 ladies, and then they brought Marlow, and I thought, oh, she looks so young, but, oh, she has been my dream nurse. I can't say enough about her. I will admit I get a little anxious when she calls and says she will be over at a certain time. And if you knew me, if she's not here, say 5 minutes after the first time, I think, oh, I hope everything's okay. I know the traffic could be bad. And I am so glad when she is at the door, I can see her. I think, oh, good, here she is.
Great.
Sweet little lady. And that's another thing, the traffic here. So once you get the older adult into the car and you've navigated all of that, then you have to navigate traffic. And I'm new to Northern Virginia, so I'm still adjusting myself. So maybe you can share, any other stories about the house calls program that, that kind of highlights how other families and caregivers have responded. I hear that you guys have grown like exponentially. So,
sure. I think as soon as we start collaborating with community resources and they hear about our program, the word just really travels fast. And we receive a wide variety of referrals. Some maybe closer to that age of 65, and we have some that are up near and probably even surpassing 100 years old. A wide variety of cultures and backgrounds and ages. So it's been a pleasure, and it's only growing. And we've received a lot of complex patients, so complex medically, but then also with a lot of social work needs too. And it's been really fulfilling to help them start tackling those issues. And of course, sometimes with the stress of caregiving, there's also issues within families, family dynamics that start to rear their heads. So helping them navigate that and really working with the family to keep the patient healthy, but then also to keep the whole family healthy.
Yeah, I think one of the benefits you have with the house calls program that a primary care provider wouldn't have is to actually see the patient in the context of their own home and what are the issues and the environment that they are dealing with. And I think that you guys help to bridge kind of that gap.
Yeah, you learn a lot about a patient by seeing their home environment. I can think of one patient that, she's like in her 80s. She has asthma and recurrent asthma exacerbations, and she was relatively new to our program. We went into her home, and we're like, why is she not taking her albuterol, her nebulizers? And then we realized that she couldn't physically reach it. All she needed was an extension cord to plug in the machine and make it reach to where she sat on the couch. And it's, things like that you wouldn't see in an office. The patient would be labeled as non-compliant. But we were really able to troubleshoot and fix that patient's medical care by giving her an extension cord. So, I've walked into other patients' homes and, Grandpa can fill his pill box perfectly, but then when you look in the pill box, he's double dosing himself, which is unfortunate, but that would be, potentially hazardous to that patient. And, just to recognize things early before they become a bigger problem than they are in the short term.
Right. I think that the other side of that, what I hear is kind of avoiding hospitalizations, helping people to stay in their own home and age kind of in place or with their family caregivers just by connecting them to resources that they didn't know were there or getting the extension cord, and then the potential for medication errors and just having a second set of eyes that are skilled at looking. I mean, as a family care provider, I could be like, well, there's pills in the box, but I may or may not know how to check that the right pills are in the right box.
Right, exactly. Yeah.
And I think also with social work and social workers, there is that stigma attached to social work. So sometimes people think of child welfare, or they think of us taking children away from their homes, and it's so much different than that with our program. We want patients to stay at their homes. We want them to live happily and safely in their homes. So a lot of it is education to the family and caregivers, at least about the social work, about what our role really is when we step foot into that home, because sometimes it leads to some anxiety, not knowing really what does a social worker do. So
we had a pretty neat case.
So I would like to thank both of you for coming on the segment this evening and sharing with us what the Inova House Calls program is doing, and to try to keep people at home, to keep people out of the hospital, and living independently and healthy. When we come back, we'll talk about the Geriatric Assessment Clinic.
You know what, guys? There's a lot of tree branches and dry brush over here. We should probably move the bonfire over there.
I'm guessing Smokey liked that idea.
Hey, Hard, what's this? That's my resignation. You're resigning. Why? You've been putting me under a lot of pressure lately. That's why I'm ready to quit. Oh, I forgot. I'll do better. Please don't quit on me.
Don't let your heart quit on you. Get your uncontrolled high blood pressure to a healthy range before it's too late.
So you can't save money? That's easy as pie. Brown bagging lunch instead of going out. $6 save times 5 days a week times 10 years is $21,000. That's a lot of lettuce. Small changes today, big bucks tomorrow. Feedthepig.org.
Did you know kids who play outdoors have healthier lungs?
Totally. I did. Did you know that boys that play with dolls make better husbands?
My son has lots of dolls. But did you know terry cloth diapers breathe better?
I did.
It's totally true.
Oh, yeah.
Did you know that strollers have the right of way on the sidewalk?
Yes.
Yep, I did. Did you guys
Did you know that kids who eat breakfast have higher GPAs?
Yeah, I know.
Yeah.
That's actually what I was going to say.
Did you know babies should never touch silver? It's really bad for them.
I knew that.
Did you guys know that statistically friendly kids have more friends?
Mm-hmm. Yeah. That's obvious.
Did you know most people think they're using the right car seat for their kid, but they're not?
Parents who really know it all know for sure that their child is in the right seat at the right age and size. Visit safercar.gov/the right seat to make sure your child is protected.
I'm putting that on my blog.
I just put it in mine.
Every time I hear the alarm bell go off in school, I think it's an air raid.
A lot of houses in our neighborhood have been destroyed. I like to close my ears and sing songs whenever the bombs come close.
I'm worried our new neighbors won't like us.
But I know it's all gonna be worth it. I just want my family to be safe. But these are not my words.
These are not my words.
These are not my words.
We're back to the Inside Scoop. Here again, your host.
Welcome back to the healthcare series of the Inside Scoop. I am your host, Melissa Batchelor-Murphy, and tonight we are talking about geriatrics, the super specialist. We've been talking about several new models of geriatric care that Inova is developing in the community, a new initiative for what has historically been a hospital and clinic-based model of care. Older adults, particularly frail older adults, require a different approach than younger populations, and so far we've talked about Inova's Advanced Illness Clinic and their house calls program. But joining me now are two more members of the geriatrics team at Inova, Dr. Ramon Blanco and Dr. Dominique Danquah, who's a social worker within the clinic. So you are trained as a family medicine, but you also did your geriatrics rotation at East Carolina University in Greenville. So go Pirates. Just have to give a little shout out to my North Carolina friends. So maybe you can tell us a little bit about how you got interested in geriatrics.
So for me, mainly it was during my residency and training. I actually enjoyed going out to the nursing home, seeing patients on a regular basis, getting to know them over the course of my 3-year training. And it just felt like a calling, and I always enjoyed talking to them and feeling like I could spend more time in that type of setting. But that led to essentially going into the geriatric fellowship, which exposed me more to the outpatient side, as well as the nursing home part of it. So I just really felt like it was good medicine, rather than specializing on one thing. It was still kind of focusing on general medicine, but in the older population.
Mm-hmm. Yeah, I think that's one of the things I've always liked about it, is getting to have a relationship with that older person over time. So Dominique, tell me about how you got interested in geriatrics.
Well, I've always wanted to be a voice for the elderly and be an advocate. And in my role as a social worker, I can do that in reaching out to the community to ensure that they get the resources they need. So oftentimes you see that they don't have the resources and don't have anyone to help navigate that. And so I got interested in that because not only that, I had an opportunity to work in Richmond for their house calls program that was there, and I just found a love for it, and knowing that I was able to be that voice for the older population.
So how long had their house calls program been up and running? Because I think that's a great experience to have.
Yeah. So theirs, by the time I joined, I think it was only 2 years old. So it was fairly new, and I was there for about 2 years as well.
Okay. Yeah, I think all of these models are new, and it's kind of in response to the fact that there are more older adults in the community who are requiring care, and we can't rely on the hospitals and the nursing homes to do everything. Mm-hmm. So let's talk about the Geriatric Assessment Clinic, and maybe you can just kind of give us an overview of what services are offered there.
So this particular clinic, it is an outpatient consultative clinic. So we will review and go over a patient's kind of profile and think about the kind of complexities that come with getting older and dealing with certain conditions that come along with that. And the whole purpose of it is to help not only patients and families, but also some of the primary care providers that are out there that may not be able to spend as much time with their patients to help deal with some of these more complex issues.
Okay, and so one of the things that's different, because we've done this before, we try to keep all the buckets straight about what the differences and similarities are. So whereas with the advanced illness clinic, those patients leave their primary care provider. For the geriatric assessment clinic, they come to you for just maybe a couple of visits and you make recommendations?
Yeah, so we'll kind of review everything as far as medications, their history, what we can do to help minimize certain risks like fall risk or even something like polypharmacy where you can easily confuse medications or take too many by accident. Memory issues we also want to look into. So essentially we're trying to reduce these kind of high-risk conditions and give recommendations to the primary care provider who can follow through and see how things change over time. I have seen a couple patients actually in follow-up, after we make an intervention. We kind of want to make sure that things are stable and that we haven't done anything to create more of a mess. But with that said, the whole purpose is to keep a patient with their regular doctor as well, because they may have been with that doctor for 30 years and they're not necessarily looking for a new doc with our program.
Okay. So what other types of, so we obviously have social work, and we're going to get to you in just a second, but what are some other providers that are in the clinic?
So we also have a nurse, her name is Lucy. She comes in and does some of the cognitive testing and physical testing as well. And then we also have Dr. Burgett available, who specializes in both neurology and psychiatry, but likes to focus on the geriatric population as well.
Okay, so I think we have a video of Dr. Burgett introducing herself, and she does geropsychiatry, which is basically helping older adults with their mental health needs as well. So we have a video now of Dr. Burgett.
Hi, I'm Dr. Tuna Burgett. I'm a fully trained neurologist and psychiatrist, and I'm the director of the outpatient geriatric psychiatry department here at Inova. I often work together with Dr. Blanco in evaluating patients over 60. My focus, of course, is the brain, where, as we all know, many cognitive disorders are part of the aging process. And I evaluate a lot of patients who have cognitive concerns, Alzheimer's disease, vascular dementia, Parkinson's-related dementia, and further. I often also see patients with common psychiatric disorders, such as depressive disorders, anxiety disorders, obsessive-compulsive disorder, psychotic disorders. And more frequently than not, I see patients who have a combination of brain and mind disorders. So a patient who has cognitive concerns and anxiety at the same time, or a patient with Alzheimer's disease and depression. My expertise in both neurology and psychiatry help me in evaluating and hopefully treating and helping my patients. I look forward to expanding my practice in Northern Virginia and the Metro DC area. Thank you.
And what's really interesting about Dr. Burgett is that for us we have around 7,000 geriatricians in the whole United States, and it seems like I have all of them with me tonight. But to have a neuropsychiatrist on your team really is a rarity that I don't think that people really think about, because that, the geropsych expertise is like a little diamond in the rough. So it is great that you have her on your team as well. And I'm talking to her about potentially doing a show later in the year around mental health needs of older adults. So Dominique, so you're the social worker within this clinic, so maybe you can kind of tell us how your role is either similar or different to the house calls clinic or program.
Okay, so there are some similarities, but there's, of course, a difference in the fact that it's in the clinic. House calls, of course, the social worker would be going out. And I'm also part of the house calls team, so I do go out to see some of the patients in the home. But within the consult clinic, my role is to do a comprehensive biopsychosocial assessment. In that assessment, I'm able to see what their physical and emotional needs are, as far as whether they need extra equipment in the home, as far as a walker or a wheelchair. And also in that assessment, I'm able to see if there's any depression that's going on. Although our nurse does the depression scale, I'm able to assess that and then give some resources as far as in-home therapy is concerned. So that's what my role is just to assess the patient holistically and to make sure that they're receiving the care that they need.
Okay. So what would be some of your clinical goals for the patients that come through the clinic?
My clinical goal is to really ensure that when they leave the clinic, they have the resources and the information that they need to better their care. Oftentimes, caregivers come in and they're so burned out and they don't know that there's caregiver support groups. They don't know that there's respite care. They don't know that there's, Meals on Wheels, these type of county resources to help them. So my clinical goal is to ensure that I've empowered not only the patient, but the caregiver.
So if I'm a caregiver at home now watching, do I have to have a referral to come see you guys? Can I self-refer? If I'm not going to leave my primary care provider, so what do they need to know to make or to contact you guys and get services? Who's eligible?
Yeah, so I get self-referrals, even from patients who have been in the hospital. They'll get recommendations from the hospital team to come out and visit us. So it can come from a primary care provider, it can come from self. I even have patients who come from, out of town, so like they're moving into the DC area because their adult children are here to care for them. So with that said, we get it from all angles, and you just contact our number and we'll get to you.
Okay. Any particular days of the week that the clinic operates?
Yeah, so currently we're on Thursdays, all day Thursdays, and we do set out a block of 2 hours per patient. And even like if we have somebody come back and follow, maybe a little bit shorter, maybe closer to half hour, but there's a good amount of time to be spent.
So say that again, because I'm sure people watching are like, how much time are they going to spend?
Yeah, it's 2 hours is what we get allotted.
So the first visit is a 2-hour visit where the nurse, the social worker, the geriatrician, possibly the psychologist. So it really is just kind of whatever you felt like you needed and you told them when you made the appointment. The whole team is standing by for a 2-hour visit.
It's multidisciplinary, so that's the whole goal, is to be able to look at you from different angles.
And then when we come to do a follow-up, that's usually about how much time?
So far, about half hour. We try to set it up that way so that we can still have a little bit more time than like I would give in my general clinic, but to be able to check up on the intervention and make sure things are going the right way.
Okay. So very quickly, I want to thank all of you for being here with us this evening. Is there anything else you would like to add?
We're here for you.
Okay. Yeah, I mean, it does really sound like with the clinic, it's a chance to do a really deep dive with these older adults and their families, and that you really are there to help them get connected and get the support that they need so that both people can be healthy and stay at home.
Absolutely.
So I'd like to thank you for being with us this evening. You can check out my website at melissabphd.org to catch up on the shows that we've done in the past. Our next show will be April 17th, 2017, and we'll be discussing the niche program, which is Nurses Improving Care for Health Systems Elders.